start with is a story about when I was an R2. So I was an R2 and had my, what was then called clinic, not continuity clinic, because we really didn't have any continuity, at the VA. And one of my patients was a retired police officer who had a long history of rheumatoid heart disease and was developing more and more congestive heart failure, worse and worse. I was working with my faculty preceptor who was, you know, an amazingly attentive person. And I remember going into him to say, he's getting worse and worse. He's more and more short of breath. What do I do? And the faculty preceptor looked at me and said, you know, I think it's time to let him go. And I was thunderstruck. I thought, wow, is it up to me to make this decision? Of course, you know, of course it wasn't, but being in the state of thinking where I was, that's what really grabbed me. And so I don't remember a thing about actually talking to this patient. I went in and I'm sure I said something, and all I remember was thinking, gosh, is this what's happening? And as I have gotten further in my medical career, I mean, my hope is that you, especially who are R2s now, can get to where I am now a lot faster with a lot less trouble. Because you know what, I think the technology has improved. And when I talked about end-of-life care, you know, probably over a decade ago here, I talked about how good deaths can enlarge us and bad deaths diminish us. But I didn't have a lot of data. And you'll see today that the situation is quite different. So here's what Randy and I are going to do. We're going to give a little overview of palliative care, what it is now, and why it's time for a center here now. We're going to highlight a couple of really important research initiatives and some of the reasons that I think the texture of palliative care and the clinical practice have really changed. And we're going to talk about what the center will do, I mean, I hope for all of you. Because one of the things I'd like you to leave with is a sense that all of you in your specialties and subspecialties actually do palliative care, and that you are part of the community that we are trying to develop here, because it's part of the fabric of what you do. It's part of what makes medicine the practice it is. It's not just about being a technician, it's about being the healer at the bedside. And you know, one of my friends pointed out to me, he's a social media guy, and I was trying to get advice from him on Twitter, but he was saying, you know, they even had doctors on Star Trek, right? So even though, you know, Eric Topol was talking about the creative destruction of medicine, and in the future, you know, the guy at Sun Microsystems thinks the doctors will be gone, I actually think there will always be a role for people who bridge that interface between what's health, what's illness, what do we do? So I think that's not going away. So to get to our topic, like, what is palliative care? I mean, and honestly, it's confusing. I mean, I could understand why there's a certain amount of confusion in your mind about what really is it. Yesterday, I was at a meeting where a layperson said to me, my friend with horrible cancer went in to see the doctor, was struggling with symptoms, was freaking out in terms of coping, and said to the doctor, what about palliative care? And the doctor said, oh, you're not ready for that. And I think, and if you take one thing away, it would be to say, I think there's another way to do that. But my other point is, I think that doctor was well-intentioned. I think the doctor meant to be comforting, as if to say, no, you're not dying yet. I really think that's what that doctor meant, because I see this over and over again. So what is palliative care? And so the definition has evolved a little bit over the past decade, and so I wanted to just point out what we're talking about. So we've gone from this idea of palliative care as brink of death care, you know, like what I was doing with my retired police officer. You know, he died like 10 days after we talked about letting him go, without hospice, I have to say. But we were thinking about it as brink of death care. You flip this switch, move into this other mode, someone dies pretty rapidly. And that's what we used to think about as palliative care. Now, we think of it as an integrated and simultaneous kind of care that goes along with disease-modifying therapy. So as your disease progresses, what we should be doing as medical clinicians and a medical system is start to move towards a bigger and bigger proportion of the amount of time, energy, and effort that we put into dealing with symptoms, helping people cope, helping them talk to their families, etc. And then there's this other part that happens after death, which of course, you know, when I was in R2, it wasn't even on my radar screen. But then later, I went to a cocktail party, and somebody said to me, when my mother died, I didn't hear a thing from my mother's doctors. When my rabbit died, I got a card and a phone call from my veterinarian. I thought, you know, there's something, something is not good about this. So anyway, what if, so, you know, I'm serious, you know, the vet school, they know how to, they're all over this. It was an eye-opener for me. But anyway, so what is palliative care? So palliative care is specialized medical care for people with serious illness, relief from symptoms, pain, and stress. The goal is to improve quality of life for both the patient and the family. So in a way, there's a social network aspect to it. There is a team that provides an extra layer of support. And it's appropriate at any age and at any stage. And you provide it together along with curative treatment. So palliative care is specialized medical care that's supposed to improve quality of life, that provides an extra layer of support, and happens at any stage. That's palliative care. Now, I mentioned the terminology is a little complicated, so I'd like to just unpack how we use the terms now. So I think of palliative care as really the big tent. This is what all of you do. It's about improving quality of life for patients with serious illness. I think of end-of-life care now as a subset within palliative care for patients who are recognizably entering this last phase of life. And, you know, of course, all of you who've been on the wards know that recognizing when it's the last phase, that's actually pretty difficult and not clear-cut. And yet, I just mean to put end-of-life care here as a subset of palliative care, because I really think palliative care now, in the national dialogue that's happening, palliative care is the big tent. Hospice care, now most commonly is used in the United States as a term for a service delivery model. Now, you know, those of you who have been here for a while will know that that's not how hospice started. And, you know, when Dame Cicely Saunders started this, I mean, she started hospice with a philosophy that was about a kind of whole person care that is now what we would call today patient-centered care. And I'm sure she's probably, you know, right now rolling over in her grave that I'm talking about it this way. And yet, because of the influence of the Medicare hospice benefit and how that structures medical care, that's how the term most commonly is used in the United States. You know, the rhetoric in the popular press has been, you know, distracting to say the least, you know, destructive in some ways. You know, palliative care in the original recent healthcare bill was framed as a death panel. You know, people you don't know who are going to decide and tell you whether or not it's time to pull the plug on Granny, right? The news we covered with a big plug. I didn't even bring it because I don't actually want to reinforce this image. But when you ask Americans, you know, what do they really think? I mean, it's really quite different. So look at this. It's important that patients and their families be educated about palliative care options available to them along with curative treatment. 97% agree. I mean, that's as close to unanimous as you ever see in these opinion polls. How important is it that palliative care be a top priority for the healthcare system in this country? 96% think it's important. So what this is telling me is that we're actually, despite the rhetoric, despite the whole thing about pulling the plug on Granny, I mean that actually in this country we are approaching a different moment and maybe a little bit of a tipping point in how the public thinks about what is happening here. Because I think what they see and what, you know, I certainly see is that their stories that they're telling at their kitchen tables about how their families are living with a life-threatening illness doesn't match that old model of palliative care that we were talking about before. Right? So the issue is, you know, why talk about this now? And I'm going to talk about two kinds of things that I think make a different kind of case for why we all need to pay a different kind of attention to palliative care. One is about data and empirical studies, and remember I said there was more data now than there was before. And then the other is about what institutions and healthcare systems see in palliative care that is really important. So the data, and I mentioned this, is actually accumulating in a huge way, but I'm going to just show you one paper. This is really, the recent landmark article, I'd say, done by Jennifer Temmel at Mass General and her colleagues, Early Palliative Care for Patients with Metastatic Non-Small Cell Lung Cancer. In this study, they randomized over 150 patients who were newly diagnosed with metastatic lung cancer to early palliative care or usual cancer care. So, you know, usual cancer care at MGH is pretty good, actually. The early palliative care arm, in addition, had a visit with a palliative care clinician just about every time they saw an oncologist. So in fact, the study actually defined that as every 3-week visits, because that's usually when people get lung cancer chemotherapy. And the median number of visits that one of these patients got was 10. So it was a lot of contact with a palliative care clinician. And what did that do? Well, you know, it improved their quality of life. So this is a quality of life measure called the Trial Outcome Index that is based on a widely validated quality of life measure called the FACT, which is Functional Assessment of Cancer Therapy. And so you can see higher numbers are better quality of life. And this is not only a statistically meaningful change, but a clinically meaningful change. You know, the challenge for me as a clinician is, how do these quality of life measures map to what I see? That's hard. So I'll just have to tell you, this is a meaningful difference. The second thing is early palliative care reduced symptoms. And this is the graph of mood symptoms. These are all done at 12 weeks. That was their first primary endpoint. So you can see palliative care is in blue, usual care is in kind of this red-brown color. And for the depression, which is depressive symptoms, subscale of the HADS, and the PHQ-9, which measures depression, I mean, there's clearly a statistically significant difference in the proportion of patients with mood symptoms. So what that means is they're coping better. They're less distressed. They're less freaking out. And actually, they're taking up probably less of your time as the clinician. And then finally, early palliative care improves survival. You know, not maybe what you would expect, but very interesting, because what this means, I think, is that taking care of people in the whole person way, that actually is good for them in a biological way, right? So that the patients in the early palliative care group had a median survival of 11.6 months. The standard care group had a median survival of 8.9 months. That is right around the established survival for patients with metastatic non-small cell lung cancer, which is typically around 9 months. And when you adjust these patients for age, comorbidity, et cetera, the difference is highly statistically significant. And, you know, when I go to cancer meetings, I typically go to these huge lectures with talking heads on video and rows of analysts standing in the background. And if this were a cancer drug, there would have been a row of analysts talking on their cell phones before the presentation was done, right? That's the world of cancer now. You know, you might ask, what did these early palliative care people do, right? I mean, in a way, one of the big questions is, you know, what did they do that led to this difference? And if you talk to them, what they think it's really a kind of a communication intervention. So I was part of a group that did a kind of a follow-up qualitative study of what clinicians did. And they did, you know, early on in the course, they did 4 things. They built rapport. They talked to people about their treatments in more detail with, I think, somebody who wasn't part of the treatment team. They improved patients' illness understanding. They enlarged patients' awareness of what their prognosis was. And when they say enlarged prognosis, what they do is actually very subtle, and we've written a whole separate paper about that. The first one is in press now in archives, and the other one is just getting submitted, about what you do to enlarge and cultivate someone's prognostic awareness. It's not about just talking about the data. And I'll show you a little follow-up stuff from our own side about that. The other thing I wanted to mention is what institutions see in palliative care. And you can see that, you know, even as this data was getting collected, hospitals are making huge investments in palliative care. And this is the growth of hospital-based palliative care programs over the past decade. And you can see it's pretty steady. And really, that has been on the strength of experiences of frontline clinicians who say, we really need this, and feedback from families and patients who say, this is really helpful. So there's really been this huge growth of these palliative care programs. And I think that's the other reason we're kind of at a public tipping point, is that now there is enough access that people see that this is real, it's available. So the second part of the institutional piece is the cost. So this is an interesting slide from Bloomberg News, right? So this is a guy who died of renal cell cancer, and this is the costs per day for the first 5 years of his illness on the left, the last 2 years in the middle, the final week of his life at the end. So look at this. First 5 years of his illness, $129 a day is what his insurance paid. The last 2 years of his life, $467. The last week of his life, over $8,000. And his wife, Amanda, says the only thing she knows for certain that money bought was confirmation that he was dying. Ouch. You know, that is, you know, there's something wrong with this picture. And you know what, this is an anecdote that kind of actually gives a reasonable representation of how Medicare dollars get spent at the end of life, but actually there's more data that backs this up. So you would think if you buy more, you get better, right? Normally in the world, the great market, that is somewhat true, but not here, not here. So look at this. This is per capita cost of an illness. This is from a large multi-center study of patients who died of cancer in the United States that was done by Holly Priggerson's group at Dana-Farber. And they looked at how much people spent for their illness and how much was spent actually, how much was charged versus the quality of death. And you can see the quality of death actually has an inverse relationship to the amount of money spent. So that, you know, combined with an anecdote like the one before, you know, I think that is really troubling in terms of what we do. And I think it speaks to the power of what the usual pathway for patients is in many of our medical systems. Now, you know, knowing you all as I do, I mean, I know that that is not out of bad intentions. It's not about sloppiness. It's not really about not wanting to do the right thing. It's that, you know, our systems and our clinical expertise are not set up to dovetail in a way that actually looks at these complicated issues in ways that patients can make decisions that match their values, right? That's the rubric right now. So that's why palliative care now. And now what I'm going to do here is build on some of that with some of the interesting research that Randy and I have done. I'm going to talk a little bit about communication. He's going to talk about integrating palliative care into acute and critical care, and he'll take over as soon as I'm finished here. But you know, going back to this issue about communication, because remember I said in that randomized trial that those investigators think basically it's a communication intervention. I mean, this is a moment of truth, right? When you're sitting there with your patient. And you know, what I didn't realize when I was an R2 talking to that police officer is that I could have a really positive effect. I could make the best of a really difficult situation, or I could have a really destructive effect. And I didn't learn that for a long time. It wasn't till, well, I got a little kick in the head later in the year because a patient of mine with prostate cancer who lived in Eastern Washington, he was dying of prostate cancer, and I said to him and his wife, well, you know, you don't have to come back and see me anymore because, you know, I'm not really doing anything. Right? I was an R2, remember? Okay, so then like a month later, right when I was supposed to see, when I would have normally seen him, his wife called me and said, you know, he would like to come back and see you again. And I said, really, for what? And she said, because I'm so dense, right? And she said, well, you know, he wants to talk to you. And I thought, ooh, I missed the boat, right? I really missed the boat. There was something happening there that I wasn't aware of and that I wasn't using in a certain way. And so part of what I've done is try and figure out, you know, what's going on there. Because, you know, for all of us who, you know, all of you who sit in this room, I mean, you are involved in some pretty high-tech things. And these are, in fact, really complicated. And the complexity of what we do has rapidly escalated. So here's an audio recording study that we did at the Hutch and at the Dana-Farber. This was a study of patients with hematologic malignancies who were coming for a second opinion. This is 40 hematologists, 236 patients. This is like the largest study of any of this kind that's ever been done. And these were patients who were early in their illness, and these consultations went on for an hour, over an hour median, and the patients got 9 treatment recommendations per consultation. These are 9 major things. So that's like one every, you know, 6 minutes. It's like they're just coming at you. And the doctors talk like they give you, they sound like, you know, God bless them, because I do, you know, I'm constantly fighting myself doing this too. I mean, you lay out the medical information as you know it, and it's my structure of knowledge. It's not their structure of knowledge. So I listen to these things, you know, with my research hat on, and it sounds like I'm an ASCO, right? Like they get up at the whiteboard, they do these things, and you know, they are trying to be really honest and really complete, right? That I know these guys, I would send my family member to them. And yet, you know, what happens is a little different. So, you know, they all think they're doing a good job, and so we all think we're pretty good, right? But when based on the data that Randy and I collected from residents here, right? This is us. And, you know, it's a little sobering. You know, there are some people who are, you know, like the guy, the dot right at the lower left. I mean, that guy is really honest. Whatever you say, that guy is really honest. So there's nothing to that. And yet, we don't, so we think we're pretty good, but we don't always, so we don't really always know when we're like, we're not connecting, right? So this is back to this hematology study. The physicians rated their patients, you know, having a spectrum of, you know, understanding, right? We all see people who seem to have a variety of ways of taking information in. And here's what the patients said in terms of, did they agree on their prognosis? So 70% of them overestimate their prognosis immediately after the visit by more than 20%, right? That's a lot. Like more than 20%, that's enough when you're talking about having a stem cell transplant, or you're talking about having some gigantic life-saving, life-altering procedure that has a very significant risk of death related to treatment. I mean, that's enough to maybe affect your treatment choice, right? So that is, it's a little, you know, again, a little sobering. And you know, when you listen to some of these audio recordings and interview the patients later, I mean, it's clear that, you know, we're not always aware that we're like using more than our share of airtime, what I call airtime, right? So here we've talked, here during the recording, the doctor is doing their thing. The results look very encouraging, so they did another study. You know, this doctor is telling the story of how the treatments were developed. The doctor's estimate that this patient will be cured is 10 to 19%. This is the next to lowest category in the options they were given. And the patient, 2 weeks later, phone interview with a qualitative researcher who not involved with the team or visit, says he did most of the talking. He started running it down to us. There was some material in there that was quite shocking. And what the patient said immediately after they walked out of the visit, we have this research assistant chase them down with a questionnaire, and the patient says 50 to 59%. I mean, in this case, it was unchanged from their pre-visit estimate. And what that does tell, I mean, my hypothesis about that is that there is this kind of emotional hijacking that happens. You know, you're in this kind of really stressful thing, and you know, all this information just does not sink in. I mean, you hear that over and over in kind of anecdotal accounts of what it's like to be sitting in front of a doctor, even from doctors' accounts, which is really interesting. And yet, we're not that great at checking in. So I've been working on, you know, what do we do about this issue for quite a while. And this is the first project we did for oncology fellows. And what I turned to really was the expertise literature, which is all about how do professionals learn how to do what they do to be experts. And this started with a work on grandmaster chess players. Really interesting. It turns out a grandmaster chess player, if you flash the screen in front of them for 20 seconds, they can like reproduce the entire thing, because they can look at this and go, oh, this is this kind of game. Just the way you look at a patient and go, this is where they are in their illness. This is where they are in their dying. You can see that, right? You have, I don't know if you can't always say exactly how you got there. I mean, that's what the nature of this expertise, but you can say. And what you need to get there, though, is actually a lot of a kind of exposure. I mean, in the old days of medical education, we used to just throw everybody in and go, okay, you'll learn it this way. Now we have to be more strategic, more savvy, because I think there are other issues besides just, you know, throwing you into the VA and having you live there for a while, or, you know, et cetera, play volleyball, you know, drink coffee in the middle of the night and talk to your friends. But what you need, there's three things that you need. You need very specific observations. You have to learn how to listen and look at a conversation differently. You have to practice in a deliberate way, doing the same thing over and over. Actually, that does not make you better, contrary to popular opinion. So you have to practice in a very specific way every piece of the thing that you're doing. I mean, the way golf pros talk about learning golf. And you have to get a lot of feedback on your performance. And what we've realized doing this is, that's not always happening. So we've used some other kinds of coding techniques to turn these descriptions into numbers so that you can analyze them. That was work from James Tulsky at Duke. And then you can actually show behaviorally that people perform differently. Oncology fellows could learn to figure out what the patient knew and ask them what their values were before telling them that it's time to make a change, right? That is a learned behavior and skill. And this is what it sounds like. The patient, when we tested that fellows, we had standardized encounters with patients who would say this line. We could make them say this line, right? Isn't there anything more you can do, doctor? And pre-Oncotalk, the doctor says, you've had a lot of chemotherapy, haven't you? Which in my business, we would call a distancing response. And the reason is because it's like the doctor is trying to get the patient to agree that they have really advanced disease by suggesting it, just putting it out there and saying, well, don't you agree with this? And the patient's like, what are you talking about? But even though the doctor had good intentions, I would call this kind of a novice approach to this issue. The other way, this is the same doctor, the next thing is the same doctor after 4 days, and she said, same line, different patient, different kind of cancer, but same line, right? Isn't there anything more you can do? There are more things we can do, yes. This has been a roller coaster ride for you, hasn't it? And there are two parts of this, right? The first part is there are more things we can do because that's what the nature of palliative care is. The second part, and this is the game changer, right? The second part is she says, this has been a roller coaster ride for you, hasn't it? Because what she is recognizing there is that isn't there anything more you can do isn't just a question about what's the next node on the algorithm. It's about, holy cow, I'm freaking out, right? And so what the doctor is doing is responding to the emotional data and the emotional subtext of that. And that's the game-changing skill. And unfortunately, you can't learn it from just listening to me blab on now because you have to try it out. So we've been doing a larger scale study of this, a randomized study that Randy has been the PI on, and I've been a co-PI. It's a clinical elective. We've enrolled over 400 residents here and at the Medical University of South Carolina. And the novel research piece here is that we're using patient-level endpoints. So we're actually surveying the patients. That's where some of that data that I showed you at the very beginning came from. And of course, you know what? It turns out residents in this different format, same learning platform, basically learn skills too, right? And Allie Bays, I don't know, she did this analysis for us and did a great job. The next thing was, and I'm going to whip through these, is, can faculty teach this? And it turns out the answer is yes. And that faculty don't necessarily do it before, so these were faculty who went into a standardized encounter where they had to supervise a standardized oncology fellow teaching a standardized patient. And so how many of these faculty asked the learner for a strategy about how to do it? Out of our entire group of 80, 1. Right? That's the pre in the middle. So, there's room for us all, in fact, here. So we've talked about this in the book. We've actually, because of the need for role modeling, we developed a whole series of videos on the web. And then finally, my new thing is, and you'll hopefully see this in a month or so, is an iPhone app, because what I'm trying to do is bridge the distance between the formal learning that we do in workshops and in classrooms with the informal learning that is actually most of the learning that you guys are doing. So and could we use this as a learning platform for what happens next? So I'm going to stop here and turn it over to my colleague, Randall. Thank you.
Great. Thanks, Tom. So Tony set me up very nicely for what I plan to do. I'm going to talk a little bit about some of the work we've done around integrating palliative care into the acute and critical care setting, and then move on to talk about this new center. Tony and I didn't plan this, but he told a story about getting involved in this after a kick in the head. And so I want to tell a story about my kick in the head. I was an R3, not an R2, and I was in the medical ICU at Harborview. And a patient was admitted to my service, a 25-year-old man who was a construction worker and had a dog bite on his hand from a pet dog. And he proceeded to go into septic shock, multiple organ failure, required multiple pressors, was on the ventilator with ARDS. And I was in that man's room, along with the intern, and back in that day, occasionally attending. And for about, it seemed like 12 or 15 hours, almost continuously, trying to save this man's life. And it felt to me like we had a good shot at it. During that time, his parents were in the waiting room, and they were pretty much in the waiting room for most of that 15 hours because we were really busy. And he did die. We brought them in. We talked to them. And I went on about my rotations. My next rotation was at Fred Hutch, so I moved over there. And his parents tracked me down and called me up and said, "We want to come in and meet with you." And I said, "Okay." I thought about saying no, but that didn't seem like the right thing to do. And they came in and they thanked me profusely for the care that we gave their son. But then they said, "But you know what? We would have really appreciated having had an opportunity to spend more time in the room with him. It would have really made our lives so much better." And that was a real sort of jolt to me to sort of say, gosh, you know what? Maybe there is a better way to do this. And I think for me, and I suspect for Tony as well, part of what we're trying to do is to prevent the next generation of residents to have to learn this by a kick in the head and through a way that may cause harm to patients and their families. So that's my story. Let me talk a little bit about integrating palliative care into the critical care and the acute care setting. Anyone who spends time in either of those settings knows that end-of-life care is certainly something that we do a lot. Palliative care is, as Tony said, broader and a huge part of this care. These are data from Derek Angus and his colleagues demonstrating that 1 in 5 deaths in the U.S. occur in or shortly after a stay in the ICU. Staggering numbers by comparison to any other developed country in the world. The other thing that I like to show about this slide is that this proportion of deaths in the ICU, the dark bars here, is about 20% through the adult years and doesn't even begin to go down until over age 80. And with our aging baby boomers, this is an issue that we're going to be dealing with a lot. There's a lot of variability in the proportion of deaths from hospital to hospital. And it's fascinating, this variability, and it's one of the things we've been interested in studying. But here, you can actually look up any hospital in the U.S. on the Dartmouth Atlas site. And what I've shown here is the UW Medicine hospitals, the proportion of deaths cared for by those hospital systems that occur in the ICU. The gold bar there in the middle at about 20% is the national average. And then all of the UW Medicine sites are there. We're all around the national average. Harborview is actually higher than the national average. Valley, it seemed like, was lower in 2003 when they started collecting these data, but now seems to be more, at the most recent data, seems to be more at the national average. So this is something that we see a lot in the UW Medicine system. So we were very interested in communication and how to improve this. And one of the studies that we conducted was a study of ICU family conferences as a way to identify communication events and try to help clinicians understand how they do it and how they might do it better. We did a daily screen in all ICUs in 4 Seattle hospitals. If a conference was planned with the family of a critically ill patient, we contacted the attending physician and asked them if they thought discussion of withholding or withdrawing life support might come up. If they said yes, we asked if they were willing to have the conference audio taped. And then we went about consenting all of the participants, all family members and all clinicians, as well as giving surveys to them to complete after the family conference. And we had a total of 51 family conferences enrolled, which was a little less than half of those that were eligible. And it represented about a little over 200 family members and over 200 clinicians who participated in these family conferences. And we looked at the duration. On average, they were about 32 minutes long, although I think many clinicians feel like they take a lot longer than that. And then we looked at this issue of airtime that Tony talked about. We looked at what proportion of the time clinicians spoke and what proportion of the time families spoke. And in this setting, 29% of the time was taken up by family speech, 71% of the time was taken up by clinician speech. We were interested in whether either of these statistics were associated with family ratings of the clinician communication. And Jonathan McDonough, some of you may remember him when he was a resident and chief resident here, he led this effort. On these surveys, we asked family members to rate on a scale of 0 to 10 the physician's communication who led the family conference. We found a significant correlation with the proportion of family speech. It's a positive correlation, so the higher the proportion of family speech, the higher the family rated the physician's communication. There was no relationship with the duration of the family conference. We asked the family, how well did the conference meet your needs? Again, same finding, higher proportion of family speech, higher family ratings of the conference meeting their needs. Now, these are observational data, but it suggests that one of the ways we can improve this communication is to get clinicians to shut up and listen. We were also interested in, we did a number of different analyses to look at the kinds of things that clinicians did that were associated with family satisfaction, and one of our analyses was to look at missed opportunities. So we had an interdisciplinary group of investigators that included physicians and nurses, but also an anthropologist, sociologist, psychologist, look at these family conferences for missed opportunities and then categorize them. And we felt that they fell into 3 main categories. The first was missing the opportunity to listen and to respond to family comments or questions, including answering questions, as well as clarifying and following up on things that the families said. A second category, and Tony talked about this, was missing the opportunity to acknowledge and address emotions that come up during the family conference, which can be important for supporting the family, but it can also be important for helping the family get past that to a place where you can have them participate in surrogate decision-making. And then the third category we called missing the opportunity to address basic tenets of palliative care, exploring patients' preferences, explain the principle of surrogate decision-making, that the family's role in surrogate decision-making is not to say what they would want if they were sick, or even what they want for their loved one, but rather what their loved one would say if they were able to be there in the room understanding all this. And then finally, affirming non-abandonment. Through this study and through a number of others of these family conferences, we had a lot of information about how to help clinicians do this better. We wanted to put this together in a teaching tool, in a mnemonic, and we came up with this mnemonic value, where V stands for explicitly valuing the things that the family said during the family conference, A for acknowledging emotion, L for listening to the family, U for asking questions that allow us to understand who the patient was as a person, what was important to them, and what their values were, and then E for eliciting family questions, and not just once, but multiple times. And then we had the opportunity to use that mnemonic in collaboration with a group in France in a randomized controlled trial that was published in the journal in 2007, where we randomized 126 patients in the ICU. The eligibility criteria was that the attending believed the patient would die within a few days. So this is relatively late in their ICU stay. And they were randomized to either usual care or to the intervention, which was to have a proactive family conference on the day of randomization or the following day with an interdisciplinary team, and to use the value strategy, as well as to hand out a bereavement pamphlet. The outcomes for this randomized trial were to phone up the family members 3 months after the patient died and to use validated questionnaires assessing the levels of symptoms of anxiety, depression, and post-traumatic stress disorder. And I think this slide shows 2 important findings. One is that the level of these symptoms was very high in both groups, but the other is this relatively simple communication intervention was associated with quite significant reductions in the levels of these symptoms in these family members at 3 months. Another piece of our work around this family conference study that emerged was the importance of interdisciplinary communication, and particularly communication between physicians and nurses, as well as other members of the interdisciplinary team. These are data where we asked the nurse right before the family conference, what did you talk to this family about? And what you can see is the vast majority explained the equipment and treatment. Most described the family conference. More than 60% talked with the family about the patient's values, and more than 50% actually asked the family explicitly what they thought, what the family thought the patient would want in this circumstance. And when we did this study in the late 90s, this was information that was not making it to the physicians, and it was not making it into the family conference. Even if a nurse was there, they were generally quiet. And I think it was really sort of pointed out to me the missed opportunity in terms of using our interdisciplinary team to its maximal effect to help us communicate with patients and families. So based on a lot of data that I don't have time to show you, we put a lot of things together into what we thought would be an effective intervention for improving the integration of palliative care into the ICU, a study that we called IPACC. The intervention now is a multifaceted, nurse-focused, but interdisciplinary quality improvement intervention. The target of the intervention was the hospital. So we did this as a cluster randomized trial where we randomized hospitals to either get the intervention as part of the RCT or after the RCT was over. It's a cluster randomized trial because our outcomes were assessed at the level of the individual patients, and our primary outcome was to survey family members after the death in the ICU and ask them to fill out a questionnaire that we developed called the Quality of Dying in Death Questionnaire. We also assessed family satisfaction with care, and we assessed the nurses' ratings of the quality of death. So here's the basic study design. We collect baseline data everywhere, randomize 12 hospitals, 6 to early intervention, 6 to usual care, collect data again. Then the hospitals in the control group got a late intervention, and we had a late evaluation period. The primary analysis was that of the randomized trial, comparing the difference between baseline and early evaluation in the intervention group to baseline compared to baseline 2 in the control group. And then we could also look at this as a large before-after trial. Our primary analysis used multivariate clustered analyses, controlling for patient, family, and nurse characteristics, as well as hospital site. I'm not going to go into a lot of detail about the intervention, but basically the way it was structured was to have 5 components: ICU clinician education and palliative care using grand rounds, lectures, as well as training videos and educational pamphlets. We identified local champions within each ICU, nurses, physicians, respiratory therapists, social workers, and others, to come to generally a full-day training about palliative care in the ICU and how to be a local champion in their ICU. We did academic detailing of ICU directors to identify local barriers and help them come up with strategies to overcome those barriers. We collected family satisfaction data at baseline, and we actually fed that back to each ICU, showing them how they did on each item compared to the average ICU in the study, to show them areas where there might be particularly more room for improvement than other areas. And we provided system supports, order protocols and pathways, staff support programs for ICUs and hospitals to take up if they were interested and willing. We conducted this first a before-after study, a pilot study, using Harborview as our intervention site. And this shows you the outcome data from Harborview, the family ratings of quality of dying and death, which is a score that goes from 0 to 100, where 0 is the worst possible, 100 is the best possible. The family ratings were about 62 before the intervention, about 68 after the intervention, and that was not statistically significant, although perhaps a trend. And then we also looked at the nurses' ratings and actually found the same thing, about 62 before, about 68 after. Now that was statistically significant, probably because we had more nurses return surveys than we had family members. So emboldened with that information, oh, and then the other thing we looked at was length of stay. Both before and after the intervention, there was no difference in the survivors, which you wouldn't expect, but at least suggesting there were no temporal trends. And there was a significant reduction in length of stay for the patients who died in the ICU by an average of 1.7 days, suggesting the intervention may have reduced the prolongation of dying that we often see in the intensive care unit. So we were emboldened by that enough, and NIH was convinced we should be funded to do this as a randomized trial. We did it with 12 hospitals, which in retrospect was too small, but it was pretty hard to do this larger on the funding that you can get from an R01 at the NIH. These were all in the Seattle-Tacoma area. We actually enrolled all hospitals that had enough ICU deaths to meet our sample size calculations except one. And we enrolled over 2,000 patients who died in the ICU or within a short period of being discharged from the ICU. Our family survey response rates were about 40%, which is a little low, but I think given that we were sending these surveys out to families after the patient died, and we didn't even have family addresses, we sent it to the home of the patient, addressed to the family of, I have repeatedly tried to defend that response rate as being reasonable. Nurse response rates were also low, and I think that's something to acknowledge. Here's our primary outcome measure, family-rated quality of dying and death, both in the control group and the intervention group before and after, and there was no change. Nurse-rated quality of dying and death, before and after the intervention, the control and the intervention group, no change. Family-rated satisfaction, before and after in both groups, no change. You're getting a theme here, I'm guessing. ICU time to death, again, no change. So these are our major outcomes, and we really did not see any change there. We thought, well, this is hard work showing changes in outcomes. Maybe we affected the processes of care, but we couldn't detect that with the outcomes. So we looked at a number of processes of care that we sort of labeled as indicators of palliative care, and overall, bottom line, no change. There was a significant increase in the provision of social work consultations. There was actually a significant decrease in the number of family conferences within the first 72 hours. I don't believe, and I hope, that neither of those were due to the intervention. I think that's just an issue of multiple comparisons. I think the bottom line was we really didn't see an effect. So let me pause for a minute for dramatic effect. This was 5 years of my life. I don't even want to tell you what the total costs, directs and indirects were, and we really didn't have an effect. It actually took me about 1.5 years to be able to present these data publicly. I made Ruth, who's up there in the back, analyze it every which way, and it was a pretty consistent finding. I do think that we learned a ton from this, and I think we learned a ton that has implications for the center effect, the center effort that we're now putting into place. One lesson that we learned is that when we did this at Harborview, I believe we made a difference. I believe those findings. We, as I like to say, we were us. We were doing this in our hospital in a system that knew us, and we had the support all the way up, not just in the ICU directors, but to the CEO's office and the medical director's office, and there was a lot of support for what we were doing. When we went out into the community hospitals and the other hospitals, I was smart enough to get the support of the ICU directors. I had that. I wasn't smart enough to realize that that's not enough. These are busy people. They've got a lot on their plate. And I see Tom there. They need support of people like Tom Sager. They need support of people like the CEOs of the hospital. It really needs to be an effort that's bought in from the highest level of leadership, I believe, to make a change at this level. Secondly, when we did this study, a lot of these hospitals, few of these hospitals had palliative care consultation service, and so we were using a model of training the ICU clinicians to provide primary palliative care, the palliative care that all of us should be able to provide, caring for patients with serious or life-threatening illness. I believe that that's not the best model. The best model is to do that plus having palliative care consultation for the particularly difficult or more complicated cases. And I think that the data in the literature supports that that is a more effective and easier way to make a difference in the experience of patients and their families. We tried to teach communication as well as other issues in settings like this. And as Tony already told you, that's a waste of time. You can't learn a skill. You can't learn to drive or put in a central line by watching somebody talk about it. You need to practice. You need feedback. And I think that was a lesson that we learned. We fed back a lot of data to these hospitals, but it wasn't actionable data. And I think that was another issue that we had. So I'm going to actually speed up a little bit because I'm going to run out of time, but I want to make the point that, and Tony alluded to this before, that there is data that palliative care consultation in observational studies at least, but with careful matching, seems to save money, reduce costs of care for inpatients, and that Helene Starks actually led an effort here at Harborview and UWMC to show that that was also true here, that palliative care consultation, particularly earlier in the hospital stay, now this is not ICU, this is all hospitalized patients, compared to carefully matched controls, palliative care consultation is associated with significant reductions in cost of care. And so I think both around in terms of improving quality and in terms of reducing cost, I think it's a real opportunity now to develop palliative care, and I think it's an opportunity to develop a center to do that. And that's one of the things that we're very interested in doing. UW Medicine and the UW Health Sciences schools, I would argue, have pockets of outstanding palliative care, clinical services, research, and education, but not an integrated program. And I think that there are very few nationally, and we are really very poised to be able to become a national leader in this. And as I alluded to in the IPACC study, leadership commitment is really important, and I have been very impressed by the leadership commitment to palliative care within UW Medicine and the UW Health Sciences schools. And so the mission of the new center is to improve palliative care received by patients with serious illness and their families, as well as to provide support for the clinicians delivering primary palliative care, as well, and also to develop new knowledge, educational, and clinical resources to improve palliative care regionally as well as nationally and globally. We are organized into sort of three operational groups: clinical operations, research operations, and educational operations. And I'm just putting up here a few of the names of people who have taken on leadership roles in that, and there are many others who are involved as well. We're structured currently to have two cores: an analysis and informatics core. It's going to be led by Helene Starks. An administrative core. We're also going to be starting a pilot grants program. And I think the message I want to leave is that I think it's a real time of opportunity for a center that focuses on palliative care. I think there's opportunity for collaboration across the UW Medicine sites and across the interdisciplinary health sciences schools to build clinical resources in a coordinated way and to facilitate center grants, training grants, and other ways to sort of bring people together under one umbrella. I also think there's a real opportunity to integrate across clinical research and education components. We have clinicians out there providing excellent care who are in desperate need of someone to evaluate their services, help them figure out how to do a better job. We have researchers who are looking for patient populations and research questions. I think that's just one example of ways that we can do that as a center. So what we're doing is we're undertaking some strategic operations planning in each of these areas. We're looking nationally for national benchmarks so that we can develop specific milestones for the center, as well as to identify, we have startup funds. Thank you, Bill, and Paul Ramsey for that, as well as Rob Glennie, who was really centrally involved in getting this off the ground. We're going to be identifying additional sources for funding. We have an inaugural lecture coming up October 8th. I wanted to let people know about. Susan Block, who's chair of the Department of Psychosocial Oncology and Palliative Care at Dana-Farber and co-director of the Harvard Center for Palliative Care, is coming out to spend several days with us to help us in the strategic planning and benchmarking process. That lecture is going to be from 4 to 5, Monday, October 8th. There will be a reception afterwards, and it's in the T wing. Actually, it's in this room. So let me finish up then by just asking the question of how you can get involved. If you're interested in palliative care, I would encourage you to join us as a member. We're in the process of putting together a way to do that. We have a listserv to keep people up to date. And I would encourage you to help us develop and use the resources that we'll be developing. If you're interested in a related field, whether that be communication, technology use and its limitations, interprofessional teams, just to name a few, we would encourage you to collaborate with us and our members. And I think if you're somebody who takes care of patients with life-limiting or life-threatening illness, then the center is planning to be a place that you can go to for support around education in both that primary palliative care that all of us do, as well as the specialty palliative care for palliative care specialists. And we also plan to collate as well as develop resources for patients and their families. We have a brand new website that was just launched this week, and I'd encourage you to visit